Morning, everyone. It gives me great pleasure to participate with Badr this year. As usual, it's always successful, and I'll be sharing the session with my colleague, uh, Dr. Fatma Kambar. She'll be starting introducing. We have three sessions. She'll be starting introducing the first speaker, Dr. Fatma.
Good morning, everyone. I'm pleased to meet you all today. I'm pleased to welcome you today to our session, which will be about metabolic health beyond diabetes. We'll be focusing today on non-alcoholic fatty liver disease and metabolic syndrome as emerging cases we see on a daily basis in our clinics. I'm pleased to welcome Dr. Naji, Professor in Medicine and Deputy Head of School of Consultant Endocrinologist, Diabetologist, and Obesity Specialist at King Hamad University Hospital and Professor in Medicine, Deputy of Head of School of Medicine at RCSI Bahrain to give this talk.
Thank you, Doctora, for the introduction. Good morning, everyone. Thank you for coming. First, I'd like to start by thanking the organizing committee. Dr. Riam, thank you so much for inviting me. I'm honored to be here. Since I've moved to Bahrain, I've attended every year, and every year I'm impressed by the organization and the wonderful speakers, so thank you. So the title of my talk is, sorry, just let me check, is MASLD and Diabetes, a New Frontier. The objectives, what I'm hoping to achieve in the next 30 minutes, are to define MASLD and MASH using the updated nomenclature and explain their relevance to cardiometabolic disease, to identify patients at high risk for advanced fibrosis, and to apply a stepwise non-invasive screening and risk stratification strategy in clinical practice, then to interpret non-invasive fibrosis assessments and integrate lab and imaging-based tools into routine clinical pathways. And then finally, I'd end by outlining evidence-based lifestyle and pharmacological therapies for MASH and to formulate a practical multidisciplinary management pathway. So first, I'm going to start about the new nomenclature. This was proposed in June 2023 by the American Association for the Study of Liver Disease. And the big change is it's no longer called NAFLD, it's called MASLD. And it's no longer called NASH, it's now called MASH. What's important is this is not just a name change. It's due to the underlying pathophysiology that's important in how we approach the disease. So let me just see if this is working. I don't know if you can see sorry, let me just get the pointer. 1 second. Okay. So if you think of this as the umbrella now, so it's steatotic liver disease, and under it comes metabolic dysfunction associated steatotic liver disease. That's MASLD. So the reason is this emphasizes metabolic dysfunction as the cause, and under that comes MASH. So the main thing is it aligns liver disease with cardiometabolic risk. I'll talk a bit more about this nomenclature and why it's important. So it removes stigmatizing language, so that associated with alcohol, that associated with fat, and it recognizes the metabolic root of the condition. So it's defining the disease by what it is rather than what it's not. So it's no longer non-alcoholic fatty liver disease, it's a metabolic dysfunction, and this positions fatty liver disease as a manifestation of metabolic dysfunction. Briefly about the epidemiology. So it's one of the leading indications for liver transplantation, along with alcohol-associated liver disease, and it is one of the most common causes of abnormal liver tests in pediatrics. So if you talk to pediatricians, it's disheartening the number of younger people now that we're seeing with MASLD. There's a higher prevalence in Hispanic, more than Caucasian, more than African American populations, and there's an rapidly increasing prevalence in Asians, including East Asians. I think that's important to highlight because it follows a similar pattern to what we see in obesity. So in Asian populations, a BMI of 23 is considered overweight and more than 27 is associated with obesity. Why is that important? Because we're seeing a similar pattern in MASLD. So people who are weighing less in Asian populations who are developing MASLD and MASH. Risk factors are metabolic syndrome, so obesity, dyslipidemia, insulin resistance, and hypertension. And there are genetic associations with PNPLA3 and TMF6F2, which I'll briefly talk about later. So why does it matter? It affects 30 to 40% of adults worldwide. So if you look around the world, the numbers are quite scary. So this is the US, more than 30%. But I think if we focus on our region, you see that our region also has a high regional burden. So the MENA prevalence is around 36.5%. It's a major driver of cirrhosis, hepatocellular carcinoma, and liver transplantation. Now, what I want you to focus on the slide is to see how diabetes markedly increases MASLD and MASH prevalence. So this is a US middle-aged cohort. If you look at here, you see the blue is MASLD and green is MASH. So I mentioned earlier that the prevalence is around 30 to 40% of MASLD, 14% in MASH. But if you look specifically at those with diabetes, so the patients with diabetes, there's a 70% prevalence in MASLD and 35% of MASH. And then if you combine it with other metabolic risk factors here, like obesity and hypertension, that increases more to 74%. And unfortunately with MASH, it's even higher to 45%. Very briefly about the pathophysiology. So insulin resistance is the main primary driver. So you have insulin resistance in adipose tissue. This leads to lipolysis. This lipolysis leads to increased fatty acid flux to the liver. The liver can't handle this. This is one of the ways this causes fibrosis. But then this lipotoxicity and mitochondrial dysfunction leads to inflammation, and that's what MASH is, and stellate cell activation. That's one mechanism. The other mechanism is this concept of hepatic hypothyroidism, where there's downregulation of the thyroid hormone receptor beta, which impairs mitochondrial oxidation and leads to lipid accumulation. I want you to just focus a bit on these two mechanisms, because when we talk about these treatments, that's where treatment comes into play, targeting these specific pathways, which will help with improvement in NASH and MASLD. I mentioned briefly earlier, so people who have this genetic variation have exacerbate toxicity, so their MASLD gets worse and their MASH gets worse. Just a slide on the natural history and progression of MASLD. So it is a chronic and progressive, ranging from simple steatosis to MASH. MASH is the inflammatory subtype of MASLD, which can progress to cirrhosis, liver cancer, or result in death. So we start with a normal liver, then due to multiple factors, there's fat accumulation as you see here. That's what MASLD. It's characterized by steatosis, and this is what I said, around 30 to 40% of patients globally have this. If we move on next to the spectrum, you have MASH, and that's where you have these three characteristics: steatosis, lobular inflammation, and ballooning. 20 to 30% of MASLD patients, that's approximately 5 to 7% of adults, will develop MASH. And again, these are important because when we target treatments, the FDA wants to see resolution in these, whether it's in MASH or in MASH with fibrosis. So MASH can progress and develop fibrosis, and that's staged into F1, mild fibrosis, F2 and F3, which is significant fibrosis, and F4, which is cirrhosis. So 20 to 40% of patients with MASLD develop fibrosis over time. Specifically about diabetes, I know a large number here are primary care physicians, endocrinologists, so you see a lot of diabetes. I think what's important to note is that diabetes accelerates fibrosis progression in MASLD. So this was a prospective study where they took around 450 patients with MASLD. Around half had diabetes, half didn't have diabetes, and they followed these patients over time. And what you see is the orange here is the patients with diabetes, the green is the no diabetes. And what you could see early on at around 4 years, you start to see splitting of the curve. So those who had diabetes have accelerated fibrosis compared to those without diabetes. Again, highlighting that there's more MASLD than diabetes, but even those who have MASLD, it progresses to fibrosis more. So increases the rate and cumulative risk of fibrosis progression. And this has been illustrated again in multiple studies followed over a longer period of time. MASLD shows worsening. Diabetes has worse MASLD progression. Few words about MASLD and mortality. So all stages of MASLD are associated with increased mortality compared with the general population. So this here is the general population. And then you see a mortality risk stepwise increases stepwise with fibrosis risk. So even fibrosis without, MASH without fibrosis, you see there's an increase in mortality, and then obviously cirrhosis is associated with the highest cumulative mortality, as you see here in the purple. I think this slide is important just to highlight why early intervention is important. So the fibrosis stage drives liver-related morbidity and mortality in MASLD. Here on the left, you see the risk of severe liver disease compared to controls, staged here by early fibrosis, F3 more advanced fibrosis, and F4 is cirrhosis. And on the right, you see the liver-related mortality. What you could see is a stepwise increase in liver disease and mortality as the stage of fibrosis increases. But you see the inflection point at around F2 and F3, and then at F4, which is cirrhosis, it goes really, really high up. So that's why we want to identify these patients at F2 and F3 early on to avoid them reaching cirrhosis. So that is our key thing that we need to identify these patients early and aggressively treat them. Now, another thing to keep in mind, and why the name again was changed to MASLD rather than NAFLD, is because cardiovascular disease is the leading cause of death in MASLD. So patients die from cardiovascular disease, not liver failure, and you could see the differences here. So yes, absolutely, you see liver-related mortality, but cardiovascular disease is the #1 cause. Again, this highlights aggressive cardiometabolic risk reduction is essential to all patients with MASLD, and we'll talk about that as we get to treatments. So how do we diagnose it? It's categorized. You should think about this in 2 categories. So we don't want to have we want to limit the number of liver biopsies because there's non-invasive techniques to help us diagnose MASLD. There's serological testing and there's imaging. If we look at serological, there's simple score like the FIB-4 index. This is something that's clinically available whenever you get a blood test. And we'll talk a bit about more of that. In certain settings, there are proprietary predictive scores like the ELF score. These are available in certain regions. But then the second part to focus on is imaging, specifically elastography. Many of you have heard about the FibroScan, which is a way of looking into fibrosis and steatosis. So it's basically looking to combine a non-invasive lab test and a non-invasive imaging test to help diagnose MASLD and MASH. So a bit more about the FIB-4 score. So who do we screen for the FIB-4? It's all patients with type 2 diabetes, patients with multiple metabolic risk factors, those who have some sort of ultrasound or imaging incidentally discovered to have steatosis. The aim is not to screen the general population, but really to identify these patients. So what's the FIB-4? It takes into account 4 factors. And again, think of your patients and think of how easy it is to do this. There's age, there's AST, ALT, and platelets. And then a formula, if you like you use your phones to calculate atherosclerotic cardiovascular risk on patients, you could use the same for the FIB-4. In fact, it's often incorporated into medical records that it incorporates this straight away. So this is the formula for it. And then you come up with 3 possibilities. Less than 1.3, this is considered low risk. And why is that important? Because it has a negative predictive value of more than 90%. For these patients, in general, we can reassure them, follow them over time. A score of more than 2.67 highlights a high risk. And for these patients, you want to refer to gastroenterology and hepatology. And that indeterminate range is where you need another sort of test to try to help confirm before you refer them on to gastroenterology. So that's where we use step 2, where you clarify the risk with elastography. That's something like the FibroScan, so vibration transient elastography. So we do it on those with patients with a FIB-4 of more than 1.3. Just remember the last slide. So those in intermediate or high risk. And what does the FibroScan do? It measures liver stiffness in kilopascals, and that measures fibrosis. There's a CAP score that comes, which looks into steatosis. Years ago, this machine was quite big. You had to walk it into a patient's room or do it. Now they're tiny probes that you could do. So they're easily available. They're relatively, compared to the benefit, they're relatively non-expensive, and they're extremely essential for diagnosing MASLD. So you obtain something like a FibroScan, and then again, it risk stratifies into 3 possibilities. Less than 8 kilopascals, more than 12 kilopascals, and that in-between range. For those less than 8 kilopascal, it's a low probability of advanced fibrosis. We monitor these patients. For these more than 12, it suggests advanced fibrosis, so meaning F3 to F4, and you want to refer them to hepatology for further evaluation and treatment. And this indeterminate range, again, we'll talk about what you do next, but that's where you consider additional imaging, and that's what's typically done with gastroenterologists and hepatologists. So this is an algorithm from the American Association for the Study of Liver Disease, and just how it should be used with primary care or endocrinologists or non-GI specialists. So if we go through a patient, you see them in the clinic, they have the risk factors like type 2 diabetes, you calculate a FIB-4 score. If it's less than 1.3, you just reassure them, follow them every couple of years if they have type 2 diabetes. Now, if their score is more than 1.3, if it's more than 2.67, refer them to a specialist. Those in between, as I mentioned earlier, so you do a fibroscan. If it's less than 8, you reassure them and go back to this side. But if it's in more than 8, that's when you want to refer them to GI and hepatology. What do gastroenterologists do? They will do further testing. They could do imaging like an MR elastography. You can do T1 weighted imaging just to get a better picture about this. And in certain situations, much rarer than before, a liver biopsy is done. But this is really important because it helps stage the fibrosis to figure out what's treatment. So all of us have access to FIB4. We need to do this. But now what's happening in reality? And this is what's concerning. So this is a real world MASH screening study. So they took patients, so it was a Delphi database. They took 633 patients with MASH. They did a sub-analysis of 100 at-risk patients managed by PCPs. So they retrospectively looked at the data. 73% of them were at risk and had a FIB4 of more than 1.3, but only 1% of them had their FIB calculated by PCP. So yes, we have guidelines, but unfortunately, these guidelines are not being applied. So I think if that's one takeaway message I would really emphasize is calculate the FIB1 and let's start acting on it. So guidelines are there to help us, and we should be using them. I'm going to transition now in terms of treatment. So I'd like to think of this as a pyramid. So the cornerstone of treatment foundation is the cardiovascular disease risk reduction. So I highlighted that this is a metabolic disorder, so we need to make sure we optimize blood pressure control, lipid management. What we often see is with a bit of elevated LFTs, doctors worry and they stop statins. That should not happen. These are the patients that specifically need statins because they're at high risk of cardiovascular disease. That's what I showed earlier. So, and in fact, in addition to their cardiovascular lowering, statins may reduce fibrosis progression. The next part is diet and exercise and GLP-1 agonists. I'll talk about GLP-1 agonists later, but we know that a modest weight loss of 3 to 5% reverses steatosis. A greater weight loss is needed for more. And then we'll talk a bit more about resmetirom, which is a TSH, a thyroid hormone receptor beta agonist, and that's specifically targeting F2 and F3 patients. So I think it's a must that I just spend a minute to talk about lifestyle and weight loss. So this is important, the 3 to 5% weight loss, just when we're talking expected goals with patients. When we tell patients that we want them to lose weight, they often think automatically of 10, 15, 20%. Absolutely, that's important. But even a 3 to 5% weight loss can translate to improvement in reversing steatosis. Now, the greater the weight loss, the greater the benefits. So absolutely, we want them to lose more than 10%. But if we just start with 3 to 5%, that will have an impact. How do we do this? Caloric deficit. There's some studies to suggest that the Mediterranean diet is important. Exercise. Exercise is really, really important. And the reason I mention this is there's been multiple studies that have shown that people who do this exercise of around 150 minutes per week without any weight loss will have improvements in their steatosis. So really to emphasize the importance of exercise in helping MASLD management. There are studies to show that 2 to 3 cups of coffee per day is associated with reduced fibrosis and hepatocellular carcinoma risk. Now, moving on to therapies. So in the last couple of years, there's been 2 drugs that have been approved specifically for MASH. The first one was approved in March 2024. And this is the FDA approved the first treatment for patients with liver scarring due to fatty liver disease. It's called Resdifra or resmetirom, and I'll talk a bit about that later. And then in the last few months, Wegovy has been approved specifically for patients with MASH. A few words about resmetirom. So resmetirom is a selective thyroid hormone receptor beta agonist, which is approved for MASH. So I mentioned the pathophysiology earlier, but just to emphasize it again. So we know that there are thyroid, part of the pathophysiology of MASLD is this hepatic hypothyroidism, which reduces lipotoxicity. So if we treat this with this thyroid hormone receptor beta agonist, this will reduce the fat accumulation. We know that patients who have hypothyroidism and are treated with levothyroxine have improvements in lipid accumulation. But you don't want to use levothyroxine on everyone because then you'll develop iatrogenic hyperthyroidism that can lead to osteoporosis, arrhythmias, etc. So the T cell, the thyroid hormone receptors, there's alpha and beta. Alpha is pretty much most of the places like the heart, that's where thyroid hormone works. But then beta is specifically for the liver. So this drug specifically targets the beta receptor. This is from a New England Journal of Medicine paper published a few years ago prior to changing the names. That's why you see NASH and NAFLD instead of MASLD and MASH. But they randomized patients into two groups. A placebo group, so these are patients who had MASLD and MASH, randomized them into two groups. And what you clearly see is that the patients on resmetirom have great benefits, whether it's in resolution of MASH or improvement in fibrosis by at least more than one stage. And the FDA requires this for them to get accelerated approval. So they need to demonstrate this for any approval, and that's what they were able to show. So to summarize that study, the Maestro-NASH study is, it met the primary endpoints, which are MASH resolution in 30% of patients and fibrosis improvement in 26% of patients. This improvement is independent of weight loss. And in addition to this, you see improvements in LDL of around 15 to 20%. It's a relatively safe drug, 2 doses approved, 80 to 100, 80 and 100 milligrams, depending on the weight. Very safe. Main side effects are some nausea and diarrhea, and that improves over time as long as you counsel patients beforehand so they don't stop it prematurely. Moving on to semaglutide. So this is the ESSENCE trial that approved semaglutide 2.4 milligrams or Wegovy for MASH and with moderate to advanced fibrosis. So in that study, they took 800 patients who had biopsy-proven MASH and fibrosis stage 2 or 3. They put them on placebo or semaglutide 2.4 milligrams for over a year, and they followed them. So in terms of primary outcome, you see a huge difference in terms of resolution of steatohepatitis for those on semaglutide compared to placebo, and then also significant improvements in fibrosis in those on semaglutide compared to placebo. So that's what the FDA used for approval of this. In addition, you see weight loss, as you all know, with GLP-1 agonists. It's quite safe, and discontinuation rate was low. So based on this study, the FDA approved semaglutide 2.4 milligrams for MASH with moderate to advanced fibrosis. So how do we decide? If patients has obesity, type 2 diabetes, mild fibrosis, GLP-1 agonists or dual agonists, which I'll talk about in a bit, are very, very helpful. The benefits here are weight loss and glycemic control. If someone has significant fibrosis, then resmetirom should be considered. Now, there are studies, early studies about combining them, but nothing is approved. But you may see added benefits if you combine resmetirom with GLP-1 agonists. And then cirrhosis, there is no approved MASH drugs. We need to refer them to gastroenterology to start screening them for compensated liver disease, so varices, hepatocellular carcinoma, etc. Now, this is a very exciting field. Lots of drugs being in development. Lots will be available in the next couple of years. So you have a pan-PPAR agonist, lanifibranor, which is being studied, and lots of injectables. Tirzepatide, so Mounjaro, which I'm sure you've all heard about. There's a study in the New England Journal of Medicine that it's shown in the Synergy trial, 62% MASH resolution with Mounjaro. I suspect it will be approved for MASH in the next year or two. There's just ongoing studies that need to be published for the FDA to approve it, but most likely tirzepatide will be approved for MASH in the next year. Lots of other drugs, so retatrutide. Again, many of you would have heard about them. It's a triple agonist, GLP, GIP, glucagon. Unbelievable, excellent results in terms of weight loss, but also in terms of resolution of fatty liver disease. That will probably be approved in 2026, 2027. And then finally, what's really exciting is FGF21 analogs like efruxifermin, which I will talk about next. I think if you think about what we've studied in medical school, we were told that cirrhosis, once someone has cirrhosis, it cannot be reversed. But what's really exciting is these new classes of drugs, whether it's FGF21 analogs or even resmetirom. When you follow them forward, these patients, you are seeing a reversal of fibrosis from F4 to F3. So this is challenging the way we thought about cirrhosis. As of now, there are no approved drugs for F4 cirrhosis. These studies are ongoing. They're weekly injections that hopefully will be approved in the next several years. So just to end with some practicalities, how this should impact our workflow. So we screen all our patients with type 2 diabetes. We should screen them, calculate the FIB4 score. Remember, 1.3, 13. So if it's less than 1.3, reassure. If it's more than 1.3, go to step 2. Step 2 is when you order fibroscans. If it's less than 8 kilopascals, this is lower risk. If it's more than 8, refer them to hepatology. Consider either GLP-1 agonists, make sure they're on statins, and consider also resmetirom. So just to conclude, so this is really an exciting time to be looking at metabolic disorders, lots of advancements over time. I think it comes, the patient, we always talk about patient-centered care, but that's where primary care, endocrinology, hepatology should be working together in MDT type of format. MASLD is the hepatic manifestation of metabolic syndrome. Fibrosis predicts mortality. You see that increase from F2 onwards. Lots of new therapies available, but many more in the pipeline. And really the endocrinology and primary care clinic is the first line of defense. Early detection prevents cirrhosis. Thank you very much, and I'm happy to take any questions.